All righty, I think we'll go ahead and get started. And if the microphone is not very helpful, I'll probably just move it out of the way so I'm not slunched down, and maybe I'll bring it up a little bit. How's that? Yeah, it feels kind of weird, but we'll give it a try. As long as you guys can see me okay. Okay. Alrighty, so let's get started. Are you excited? It's the end of week 3. So I'm sort of excited. We're going to have a special guest. I don't know if she's here yet or not, but Liz will be hanging out in class today. We're going to talk about respiratory alterations and cardiovascular alterations. It should take the whole time. We'll spend probably the first 50 minutes on asthma and COPD. And then the Cahoots game at the end is going to be related to the hypertension, CAD, and heart failure. Somebody asked me to go over some of the care plan stuff. So I'm going to spend about 5 minutes on that real quick. Just so we're all sort of on the same page. First, does anybody have any specific questions on the care plan? Okay. Our main goal for this, and it's kind of a big assignment, you'll be doing it every term, is to line up the patient's diagnosis, what they came into the hospital for, along with their medications and their labs, and identifying the problems. Sometimes the comprehensive focused assessment can be a little bit confusing, especially the first one, the acid base one, and that pertains mostly to ABGs, if they have them, shortness of breath, fatigue, anything that could cause their acid base balance to be out of alignment. All of these should be filled in for the assessment part. The pathophysiology should be as thorough as possible. And even with the surgery, you should try to get to the cellular level if you can. Priority problems, those will be based on your assessments. So pick a few priority problems like pain management or whatever it happens to be. And make sure your nursing diagnosis aligns with that. Because if you have a priority problem, we want that to be your nursing diagnosis. Does that make sense? Good. All right. Any questions on that before we start the lecture? All right. Hopefully that helped a little bit. Okay. Here's the agenda. We'll have a few slides on general oxygenation. And then we're going to go through sort of a rolling case study for asthma and COPD. I think it's going to take roughly 50 minutes, maybe 45 minutes. We'll take a break, and then we'll start the second half. This out of the way. So let's talk about a few alterations in oxygenation. I think one of the biggest ones would be hypoxemia, so decreased level of oxygen in the blood. And that can be caused by a lot of different things. If left untreated, it could cause hypoxia, which is decreased oxygen level or delivery to the tissues, and can affect important organs like the brain and the heart. Some causes would be COPD and asthma. We're going to go over those. Poor oxygen exchange, like pneumonia. Pulmonary edema would be a couple of examples. Fatigue, irritability, and discomfort. Mild impairments, fatigue, lack of energy due to low oxygen level. Irritability, the brain function is a little bit less because they have less oxygen going to the brain. And discomfort, general unease from breathing fast, and just that general discomfort of that whole process. Some other alterations, gas exchange, which is the ability to transfer oxygen from the alveoli to the blood. Airway patency. Clear open airways allow proper airflow, but if they're restricted for some reason, that's going to decrease that oxygen going to where it needs to be. And respiratory patterns, rate and depth of breathing. So are they tachypnic or are they breathing slow? Damage to supporting thoracic structures, like rib fractures would be an example. Limited chest expansion because of the extreme pain from that rib fracture. Or weak diaphragm. Respiratory mucosa, the inflammation, narrowing the airways, increasing mucus. A few modifiable risk factors. These are, and when I say modifiable, that means that they can be changed. Obesity, so reduced lung expansion, increased pressure on the diaphragm, higher risk for sleep apnea. Smoking or type 2 diabetes. Smoking damages the alveoli, which causes poor gas exchange. Generally leads to chronic bronchitis and emphysema. And stress and anxiety, hyperventilating, so you're reducing your CO2 in your system, could cause dizziness and fainting. Smoking and tobacco cessation, that's pretty big in a lot of hospitals and clinics. Tobacco smoke exposure causes increased mucus, so blocking the airways. Decreased cilia action, so it's that allows poor clearance of different debris, dust, and all that. Prolonged exposure, chronic respiratory disease is caused by that. COPD, lung cancer, emphysema. Or a patient-centered approach. So we want to respect the patient's autonomy if they don't want to quit or if they're not ready to. And they're not going to quit if they're not ready, but we can provide assurance and respect their wishes. Some available nicotine replacement therapy resources would be patches, gum, lozenge, counseling services. All right. And now we're going to talk about asthma. Any questions on the last section? All right. All right, so we're going to talk about Sarah McGregor. She is a 9-year-old female diagnosed with asthma when she was 5 years old, lives with her parents and 2 younger siblings. Now, the scenario is Sarah experienced a severe asthma episode at school after exposure to paint or glue during a class project. Without quick relief medication on hand, she may have forgot it or didn't have it. She delayed seeking help, leading to respiratory distress and hospitalization. So with asthma, we know it's a chronic inflammation, inflammatory disorder of the airways. The bronchioles are hyper-responsive, reversible airflow obstruction and airway inflammation, mucus overproduction and swelling or edema in those airways. Some of the etiology, common triggers are dust, pollen, pet dander, or irritants like smoke, strong odors. Respiratory infections can be a trigger. Occupational exposure. Exercise at times can be a trigger for asthma. Emotional stress and occupational exposures like work, like different smoke, dust, or anything that's in the work area. Some risk factors would be family history of asthma or allergies, personal history of allergies, exposure to smoke, especially during infancy, obesity, occupational exposures to allergens or irritants. Some of the manifestations or signs and symptoms: wheezing, especially on exertion, dyspnea, breathing fast, or just not breathing effectively, cough, especially worse at night or early in the morning, chest tightness, prolonged expiration, use of accessory muscles like the abdomen or the sides, and nasal flaring, decreased exercise tolerance. Sarah's history of wheezing and susceptibility to environmental triggers highlights the importance of understanding asthma's etiology. Her risk factors are age, so she has a pediatric onset asthma, possible allergen sensitivity, and we don't know exactly what those are because I don't think she's been tested, and lack of immediate access to rescue medication. Question. How can asthma triggers be identified and minimized in school and home environments to prevent exacerbations? And there are a couple of them. And we'll start with Curry, and then we'll go to you guys. What do you think?
Having procedures for asthma and knowing the triggers for it.
Good. I like that one. Anything else? And anybody can answer.
Sure. To paint or glue
Oh,
or
knowing the triggers. Paint or glue. Yeah, good. Perfumes. Oh yeah, that could be a trigger. Let's take a look. So we can conduct a detailed assessment on potential allergens and irritants. And we know she was exposed to glues and paints. And we educate school staff and parents on common asthma triggers. We can encourage minimum exposure to classroom materials like paint and glue. So she'll have to do some other activity. And implement asthma-friendly school policy, like avoiding strong odors in art projects. A lot of different occupations or offices have like a small to no cologne policy too, just for that. Role of collaboration. So with everything, it's all of a collaborative process to help these patients. Severe asthma attacks require rapid intervention and emergency department visits. Includes nurses, respiratory therapists, and healthcare providers. Those are the three main ones. And the nurses play a key role in educating. An example would be a nurse notifies or notices the patient's inhaler techniques are inadequate, and collaborates with the respiratory therapist to teach that patient how to use those inhalers. Diagnostic tools, we have a few of them. Peak expiratory flow rate, or PEFR for short, or heifer. I don't think anybody says that except for me. Monitors daily asthma control by measuring the fastest speed of exhalation. Results are categorized in color coding, so green, yellow, and red. Green being well controlled, red being little to no control. Pulse oximetry, I think we're pretty familiar with that. Tracks oxygen levels in the blood. ABGs provides data on oxygen and carbon dioxide exchange and pH levels. Used during acute asthma exacerbations. Chest x-rays detect lung complications like infections, fluid buildup, or hyperinflation. Complete CBC, complete blood count. Usually eosinophils in the white blood cells, or one of the white blood cells, is elevated or present. Sputum culture identifies infectious agents. And the ECG or EKG provides baseline cardiac data. Oh, that one's blank. Any questions on that one? The case update. During her follow-up, Sarah presents with clear lungs. Her peak expiratory flow readings are within the green, indicating she's pretty stable. And this is after the hospitalization. Some highlights, clear breath sounds at follow-up, but has a history of wheezing and chest tightness. Reports nighttime coughing. And remember, it gets worse at nighttime and early in the morning. And her PEF readings are within normal limits for her age. Children with asthma often underreport symptoms. Nurses should engage both the child and the care provider to identify subtle signs of distress before things get worse. Sometimes kids can't really identify that, or they don't want to say anything. Confirm diagnosis with peak flow trends and patient history, and assess symptoms or symptom patterns to determine control level and adjust medications as needed. Pharmacological, and we're going to go into a little more detail in the next few slides. Anti-inflammatory meds like inhaled corticosteroids for a more longer term. Long-acting bronchodilators to maintain therapy. Short-acting, which would be what we'd call a rescue inhaler, or long-acting to keep the control going. Leukotriene modifiers like Singulair for maintenance and inflammation control. Rescue drugs versus maintenance drugs. We talked a little bit about that. And we're going to talk a little more about the stepwise approach to asthma management as well. Short-acting bronchodilators. Albuterol is probably the most popular. There are a few things to know about this one. And this is the rescue inhaler. So if they're having an issue, they need to take a couple of puffs or whatever is prescribed. This is a beta agonist. So it stimulates beta 2 receptors and also hits the beta 1 receptors in the heart and stimulates those. With people with tachycardia, this will probably increase their heart rate. So in the hospitals, I've seen people that have tachycardia, the provider would go with Atrovent because that's a different receptor and it doesn't stimulate the heart as much. Long-acting bronchodilators like Salmeterol That's for maintenance therapy. So for longer term, inhaled corticosteroids, anti-inflammatory control. So it just keeps things from being inflamed longer term. And things like Singulair, I think most of us know that as a allergy medication for longer term control and prevention of asthma symptoms. Stepwise, and I can't recall if there's questions on this on the test, but probably know some of these steps. So step 1, intermediate or intermittent asthma. So on occasion asthma, like if you're outside and something triggers you, you start breathing not so good, you could take the short acting or rescue inhaler. For mild persistent, low dose inhaled corticosteroid. And of note, and I think this is probably on the next slide, I can't recall, but you'll want to take the short-acting bronchodilator before you take the inhaled corticosteroid. Step 3, moderate persistent. So recommended low-dose corticosteroid and long-acting bronchodilator. Moderate persistent, step 4, medium dose and inhaled corticosteroid and a long-acting bronchodilator. Severe persistent, so it just keeps happening often, high dose inhaled corticosteroid and long-acting bronchodilator, and consider a biologic as well. And severe persistent uncontrolled asthma, step 6, high dose inhaled corticosteroid plus a long-acting bronchodilator and some kind of oral corticosteroid like prednisone. Patient education is important, because sometimes asthma patients don't quite know how to use their inhalers. We need to teach them how to use their spacers effectively, so they're getting as much medication as possible. Dry powder inhalers. We want to avoid moisture and inhalation air, so we want to teach them how to use like Advair, which is a disc. We want to educate them to rinse their mouth out after use, because it could cause fungal infections, and combine medications effectively. So like I said, using the bronchodilator to open things up before you use the inhaled corticosteroid or any other medication. All right, patient management plan. So Sarah's asthma action plan includes daily use of low dose inhaled corticosteroid and as needed short-acting beta agonist for quick relief. So hopefully she'll be carrying that with her at school. Daily control inhaled corticosteroids to reduce airway inflammation. Then we have the rescue medication, the albuterol for acute symptoms. Sarah's mother expresses concern about medication side effects. The nurse educates on inhaled or inhaler techniques and reinforces the importance of adherence, especially the longer term medications. How should inhaler techniques and adherence be reinforced in pediatric patients to improve outcomes? Because we have to teach them a little bit differently than we would with adults. Spacers, good. Yeah, demonstrations and have them repeat back, good, or teach back. Excellent. Anything else? Positive reinforcement, good. Yeah, especially at that age, they kind of need that. Let's see. So using demonstration and return demonstration to ensure correct inhaler usage, because how do we know if they're going to use it if they don't teach it back? So that's probably one of the biggest ones. And she's 9 years old, so she probably likes videos. We could find educational videos on how to use these things, or some written instructions at her level. Encourage the use of spacers to improve medication delivery. And another one that we want to think about is regular follow-ups to assess technique and adherence, because we want to evaluate that our teaching is effective. Prevention tests and therapies. Spirometry assesses lung function and helps diagnose asthma. And this also helps to see whether bronchodilators are improving airflow. Allergy testing. We want to see if there's any particular allergies that she's susceptible to. So we could do allergy testing for a whole lot of different things that could narrow things down that she can avoid. And peak flow monitoring, which we talked about a little bit. Example would be patient can track their daily peak flow reading to detect worsening asthma. Lifespan considerations, children and adolescents. It impacts their daily activity and family dynamics to a certain extent. It's important for them to have an asthma action plan early, and caregiver education is important. Challenges in adherence due to developmental and social factors. Asthma management strategies differ based on age, developmental stage, and family dynamics. In children like Sarah, play-based learning could be helpful, and visual tools to enhance education. Reinforcing parental involvement while fostering the child's independence is important. And I think we talked a little bit about this, but this kind of goes off of the last few slides. How can the nurse tailor asthma education for pediatric patients? What's that? Yeah. So age appropriate videos and visuals. Another one we talked about is incorporating games and interactive activities to reinforce learning. Provide positive reinforcement. We mentioned that to build confidence and self-management. Pregnant women, respiratory changes during pregnancy, because there's like a mass there, and breathing is probably a little more challenging. I mean, I've never been pregnant, but makes sense. Managing asthma to prevent complications, and addressing medication concerns to improve adherence. Older adults, underdiagnosed and coexisting health conditions, so they could have a myriad of different chronic illnesses. Challenges in distinguishing asthma from other respiratory conditions like COPD, which we're going to talk about next. And importance of tailored education and frequent follow-ups. A little bit of health promotion. Educate patients on trigger avoidance. Promote influenza and pneumococcal vaccines that could help prevent certain complications. Encourage regular exercise as they can, and maintenance of health or healthy lifestyles. We can encourage them to take up maybe swimming, which has less triggers than like running, where grass and other triggers are. Sarah's mother shares that the school activities often involve potential triggers like glue, paint, and seasonal changes. Some health promotion strategies would be collaborating with school staff to create asthma-friendly classroom environment. Provide Sarah with asthma emergency kit for school, like her rescue inhaler. And I think we're going to skip the next couple. Independent nursing interventions. And when I say independent nursing interventions, this means the things that we can do without a doctor's order. We can teach and reinforce proper technique for inhalers, assist with the development of the asthma action plan, educate on trigger identification, promote breathing exercises and relaxation techniques. And we can also provide emotional support and reassurance, none of which needs a doctor's order. And also, if we come in contact with a patient that has an acute exacerbation, we can place them in a high Fowler's position, encourage pursed lip breathing, and administer the short-acting beta agonists like albuterol. Nurses' role, teaching Sarah how to identify these, and kind of a repeat, encouraging the peak flow monitoring at home, and ensuring Sarah and her family understand the action plan steps. What independent interventions can help prevent emergency department visits for pediatric asthma patients? And looks like we just kind of went over that. So I'm just going to put these down here. Teach breathing exercises like pursed lip breathing.
Thanks for that.
Reinforce adherence to long-term control of medications, or long-term control medications. Educate on early use of quick relief medications, like the short-acting beta agonist. Provide information on recognizing worsening symptoms early. Nursing process, we'll kind of go over this briefly. So we want to assess what is their respiratory status, their lung sounds, respiratory rate, oxygen saturation, and what does their cough look like? Is it dry, wet, mucousy? Evaluate the patient's medical history, and that should be in every assessment. Assess the patient's knowledge and understanding of asthma management, because that'll tailor how we educate the patient. A few nursing diagnoses would be ineffective airway clearance, impaired gas exchange, and anxiety is kind of a big one. Planning. And when I say planning, this means the goals for the patient. The goals is to achieve and maintain optimal asthma control, minimum symptoms, and collaborate with the patient to develop individualized plan, provide education on self-management techniques, and encourage adherence to prescribed medications and therapies. A few implementations we can do. And this per doctor's order, we can prescribe or administer prescribed medications like the short-acting, long-acting, teach proper techniques on how to use those, educate on trigger avoidance, teach and reinforce breathing techniques. Pursed lip is a big one. Assist in development of asthma action plan, and then provide education. And then all this, we want to evaluate and then adjust the care plan as needed. Assess the patient's response to medication therapy. Is it working or not? Do we need to change something? Monitor respiratory status and evaluate the patient's understanding of their plan. And We're gonna skip the question on this one. Sarah's teacher notices her using a rescue inhaler more frequently during recess. Some action steps: assess for early signs of exacerbation, implement the action plan by administering bronchodilator, and notify Sarah's mother and consider medical follow-up. I think we can skip this one. So, and some of these are sort of repeat, and we're almost to the COPD. Key education points: importance of adherence to daily control medications, identify personal asthma triggers, again, correct use of spacers and peak flow meters, and Sarah's family agrees for regular follow-ups to adjust management plan as needed. And we went over that relatively quick. Any questions on asthma? Take a sip of this before we go to COPD. And I think we're going to talk about John next. Yes. Yeah, activity induced can happen. So that's why we would recommend activities like swimming compared to playing out in the grass. Yeah, good. All right, chronic obstructive pulmonary disease. Another fun chronic illness to have. All right, so this is James. I thought it was John, but it's James. He's a 58-year-old male, heavy smoker since high school, retired machinery worker and Vietnam War vet. Lifestyle: he recently retired, increased smoking to 2 packs a day, and enjoys gardening. The scenario is James was admitted for shortness of breath during spring after resuming outdoor activities. Initial assessment shows tachypnea, so rapid breathing, use of accessory muscles, SpO2 89%, and elevated blood pressure 164/96, which is a little high and makes sense. And he reports discomfort with his oxygen mask. And sometimes you'll see this with patients wanting to take those off. So a little bit of pathophysiology. It's a progressive irreversible condition affecting airflow due to inflammation and tissue deconstruction or destruction. Let's see, example would be inflammation in COPD leads to narrowing of the airways and damaged alveoli. So exchanging oxygen and carbon dioxide are going to be a challenge. Primary cause for COPD is cigarette smoking, which leads to the inflammation and destruction. Etiology, again, smoking, primary cause. Environmental exposures like secondhand smoke and occupational exposures. Genetic factors like this one, alpha-1 antitrypsin deficiency. And you won't need to know this one for the test, but it's good to know that it's there. So this might be an obvious question, but what factors in James's environment and history contribute to his COPD development? Smoking. Good. I was hoping you'd say smoking. Excellent. And now he's at 2 packs a day instead of whatever he was before. Anything else? Career? Yeah. I think that could be a big factor. Yeah, gardening. So there could be triggers that are causing his exacerbation. Good. So long-term smoking habit, now 2 packs a day. Exposure for probably many years to factory fumes and dust during his career. Reduced physical activity post-retirement. So he didn't really do much in the wintertime until spring came, and then he decided to be more active. All right, so we talked a little bit about risk factors. Most commonly diagnosed after the age of 40. Family history of COPD could play some role in it. Clinical manifestations, chronic cough, and that's probably one of the biggest ones. Often sputum production, at least they can get that stuff out most of the time. Dyspnea, especially during exertion. And there's different levels. So some people can walk short distances and not have an issue. Some can walk short distances and have tachypnea or dyspnea happen. Chest tightness, decreased exercise tolerance. Frequent respiratory infections, because you have a lot of mucus production and that kind of breeds infection. And barrel chest. And with your respiratory assessment last term, you probably were educated a little bit on that. So it's more of a 1-to-1 ratio when you look at their side instead of 2-to-1. James' lifestyle choices and occupational exposure place him at high risk. So again, long-term smoking, exposure to industrial pollutants, and sedentary behavior after retirement. Role of collaboration. Want to collaborate with our healthcare professionals or providers, respiratory therapists, nutritionists, because they'll probably have to eat small, frequent meals. Encourage caregivers of home-based patients to have adequate training. And encourage interdisciplinary communication to implement best practices. Diagnostic tools. Pulmonary function test is probably one of the biggest ones. Assesses disease severity and progression. Spirometry. Measures forced vital capacity, or FVC. So total volume of air forcibly exhaled after a deep breath. Thus can be indicative. Indicates lung and chest wall capacity. The other one is FEV1, forced expiratory volume in 1 second. Volume of air expelled in 1 second with a forcible exhalation. Reflex airway function, lower value suggests obstruction. Blood gas, ABG, evaluates the exchange of oxygen and carbon dioxide. And serum alpha-1 antitrypsin levels detects genetic deficiencies. I don't know how often that one is performed. James presents with shortness of breath, chronic cough with sputum, and wheezing. His oxygen saturation remains low despite supplemental oxygen. Assessment highlights he's tachypnic and labored breathing. Barrel chest, so he's had it for a while. And the use of accessory muscles, pursed lip breathing, and prolonged expiratory phase. SP2 below 90%. And I think we mentioned that COPD progression can be identified by spirometry, chest x-rays, and ABGs. Diagnostic considerations, reduced FEV1, FVC ratio. So they would take those two numbers and provide a ratio for that. Chest x-ray, hyperinflation of lungs and flattened diaphragm. So they can diagnose COPD that way as well. Then ABGs. So talked a little bit about these spirometry smoking cessation programs. So they have to be ready to quit, but we can still educate on that. And a lot of places mandate in the EMR that you click, you educated the patient on smoking cessation if they smoke. And pulmonary rehab could help. Pharmacological therapy, some of the same things as asthma. Short-acting albuterol could help, or long-acting like salmeterol. So the same two medications as asthma patients would take. Corticosteroids, either it could be prednisone oral or inhaled corticosteroid. Antibiotics if they have a bacterial infection. And combining inhaled corticosteroid with a long-acting beta agonist. One popular one would be the Advair discus. Oxygen therapy, long-term oxygen improves survival. Deliver through nasal prongs or mask, depending on severity. Titrating to prevent hypercapnia and CO2 retainers. Do you guys know about CO2 retainers at all? I don't know if we've gone through that last term at all. So I'll talk about that briefly. So CO2 retainers, what happens is if they get a lot of oxygen through nasal cannula or mask or whatever, and they're like 98, 99, 100% with the saturation, some of their receptors, I believe in their carotid arteries or aortic arch, I can't recall right offhand, would say that they're getting plenty, so they'll breathe slower and not exhale that CO2. So the CO2 is retained, which will make them more sleepy and groggy and more lethargic. So the goal for these patients is to keep their SpO2s 88 to 92%. So sometimes you'll see an order from a doctor saying keep their oxygen saturations between 88 and 92. So you'll adjust the oxygen that they're getting. Could be 1 or 2 liters that they need. And that should keep them at a good balance with the CO2. Does that kind of make sense? And you'll probably get more details on this in your patho class for respiratory. So when Heather asks you about CO2 retainer, you can say, oh, I know all about that. Well, a little bit. Patient management plan. James's care plan includes long-acting bronchodilators and inhaled corticosteroids. So probably an Advair disc. And oxygen therapy for home use. Medications, long-acting, bronchodilators, inhaled corticosteroids, and a rescue inhaler if he needs it. It's the 9:50 alarm. We'll go a few more minutes. What patient education is necessary for safe oxygen therapy use at home? What do you think?
No smoking.
No smoking? Good. And if he continues to smoke, what should we teach him?
Remove his oxygen.
Yeah, we don't want him smoking with oxygen. It's happened before and I've seen it. I mean, I haven't actually seen the guy smoke with oxygen, but I've seen the after effects. Usually not all that pretty. So avoid smoking near oxygen equipment. And since he's probably a retainer, CO2 retainer, we want him to use his oxygen appropriately. And hopefully he would have an SpO2 monitor, a little finger probe. Probably regularly check his oxygen levels and his tubing. And maintain equipment cleanliness to prevent infection. Pulmonary rehab, a couple of points here. In pulmonary rehab, they can learn diaphragmatic breathing to strengthen respiratory muscles and reduce symptoms. And they can also help with activity tolerance and quality of life. and reduce the symptoms, burden, and rehospitalization. Surgical interventions, it's not very many. Lung volume reduction surgery removes hyperinflated areas. Endobronchial valve therapy redirects airflow to healthier lung regions, and I've never actually heard of this one. Or lung transplant at the very late stages of COPD. Health promotion, educate patients on smoking cessation, same thing, influenza, pneumococcal vaccines, and encourage regular exercise as they can. And I don't think we need to repeat that. Let's go through independent nursing interventions. And these are pretty similar. Teach and reinforce proper inhaler usage. Assist with the development of a COPD action plan, like you would with an asthma patient. Promote breathing exercises and promote emotional support. And we already talked about what independent nursing interventions are. Nurse's role, educate him on that, pursed lip breathing, monitor for signs of infection, worsening symptoms, encourage hydration to thin out mucus secretions. And I think we've already pretty much answered these. I'll just put these down. Teach early recognition of exacerbation signs, like increased sputum production. Reinforce adherence to medication, and follow regular follow-ups. And schedule regular follow-ups and get his immunizations. Nursing process, sort of similar to asthma. We want to focus on the respiratory status and his cardiac breath sounds, evaluate his history, assess the patient's knowledge about COPD management. Very similar to asthma, increased airway clearance, impaired gas exchange, and anxiety. His goals, optimize respiratory function, minimize symptoms, collaborate with the patient to develop a COPD management plan, and provide education on self-management. Administer medications, prescribe medications, and these are pretty similar to asthma. Doing the teaching, diaphragmatic breathing, pursed lip breathing, encourage smoking cessation, assist in developing the COPD plan, and providing education on early recognition. And then with everything else, we want to assess the patient's response to medication therapy, monitor his status, respiratory status, and evaluate the patient's understanding and adherence of self-management techniques. And we're going to skip this last section here. Let's see, I think we've pretty much answered these. All right, let's take a 10-minute break, and then we'll play a game for the rest of it. Actually, I have a few slides on perfusion when you come back, and then we'll start the game. Definitely kept you for a nice long stretch.
Yes, not. I'm curious about it. Other stuff.
Right.
See that one.
Possibly, only if they have sleep apnea. So larger patients or patients with thicker necks would generally be on it, but they don't really have to be if they don't have sleep apnea.
What about the CO2?
It kind of depends. If they wear oxygen, then they would probably just have to manage that or turn it down. They would do probably do a sleep study to see how much oxygen at night, just so they don't go overboard.
Hospital, sometimes I've seen them actually have, see that,
Oh, yeah.
of retention. I was just
Yeah,
curious, that was
I mean,
probably,
and sometimes they'll use BiPAP too. So the biphase it in and out to get rid of CO2 as well. And some people have to wear that at home on occasion.
so it does make sense with what I've seen it.
Good. I like it when things.
I worked, I was CNA in the field.
Okay. Yeah, the area.
Oftentimes I've been in my ICU, so I see it quite often.
Perfect.
Do you all think electrolyte stuff too? So much. Okay. Yeah. Oh, my goodness. Thanks. Yeah.
I didn't even see you come in. I didn't even see you come in. Oh, yeah.
She works.
All right, we'll start up in a couple more minutes.
Like a chicken, we have 10 chickens and then one chicken for like ever. And we didn't know that it was like a food on my state. And then me and my sisters went out there to take care of the chickens and there's a little bit of chicken out there.
Yeah, when we start the game, are you gonna be able to see the board with this in the way? The yellow one? Oh yeah, the bottom. Right. Okay, yeah, I don't know if I can adjust that or not, but I'll probably just read it off like I did last time. Was that helpful?
Yeah.
Yeah, I don't know if there's a way to pause it and see if it works, but we'll find out. Yeah, well, it rolls, but I'm almost afraid to move it. I might break something. All right, let's get started. Hopefully everybody had a good break and a little more awake now. I think I am too. All right, so we're going to talk a little bit about perfusion. It's a small section in the book compared to hypertension, CAD, and heart failure. So we'll go over a few basics on perfusion. Alterations in perfusion can be primary or secondary. For primary, like acute limb ischemia, so narrowing of the arteries and decreased sensation in the limbs, cardiogenic shock, septic shock, and secondary would be like hypovolemic shock from low fluid, anaphylactic shock that could cause perfusion alterations, and multiple organ dysfunction, acute or chronic respiratory acidosis, acute, when acute ventilation failures occur. An example would be, can you hear me still? Okay. Could occur with COPD exacerbations requiring immediate intervention, like non-invasive ventilation, so CPAP or BiPAP in the hospital setting. Chronic, usually secondary to other medical conditions. Metabolic acidosis. Usually have pulmonary vasoconstriction, increased pulmonary vascular pressures. So right ventricular failure, and we'll talk a little bit about that. And myocardial depression. One way we can monitor that is tracking the ABG changes to help identify worsening metabolic or respiratory acidosis. Clotting disorders and potential for pulmonary embolism. Patient that's immobile could be at a clotting risk. Prophylactic anticoagulants like Levinox. You'll see Levinox given in the hospital quite a bit. And after next week, you'll be able to administer that. So that's given to almost every patient that comes in that's not allergic to it to prevent deep vein thrombosis or DVTs. Alterations in pediatric cardiology. So mostly congenital cardiac defects. Common cardiovascular illnesses. And we're going to talk about some of these: hypertension, coronary artery disease, myocardial infarction, and stroke. And I don't recall what week we're talking about that. Probably neurological, I think week 6 or 7. Common cardiovascular illnesses of older people, mostly changes to the myocardium, SA node firing differently. So atrial fibrillation, atrial flutter, left ventricular changes, and valves, blood vessels are not as good as when they were younger. Genetic considerations and risk factors. So non-modifiable means something we can't change, like age, gender, race, personal health history, family history. Do they have a family history of high cholesterol, early onset coronary artery disease, or some kind of genetic factors? And individuals with family history of early onset CAD should undergo regular lipid panel testing. Some common screenings: blood pressure and heart rate. Lipid panels, those identify high cholesterol levels, which is a big risk factor for coronary artery disease. EKGs, monitoring for arrhythmias or ischemias, and stress tests. And now we're going to be talking about hypertension, CAD, and heart failure with a bunch of questions that are very closely related to the slides that you have on Canvas. Let me change this over. To that. Let's see. It'll just be a few minutes. Don't use presenter notes. No, I don't want that. Let's see if that works. That keep changes. All right, I think we're getting somewhere. And let's share screen. And let's see if we can find it here. Let's move this out of the way. Make sure they can see that. Good. Okay, and it should be loading here pretty quick. All right, so everybody can log in and we'll start. And we'll see if Heather can be dethroned today. We're up to 27, 28. And Curry, can you see this okay?
Yes.
Okay, cool. Yeah, we'll wait a few more minutes. Now, the obstruction to the one question, is it because this is in the way? Okay. Yeah, I don't want it to fall over the edge. So I'll probably just read it. Another 30 seconds and we'll get started. All right. All right, we'll get started. Okay. And you have 30 seconds instead of 20 seconds on this one. So a 58-year-old patient has a BP of 150/95. Which factor is likely indicating primary hypertension? And kidney disease is the bottom one. So has 30 seconds. All right, sedentary lifestyle and family history. All right, almost everybody got that one. Good. And let's see, I'm not sure what to do with that. Okay. All right. Well, Heather's in second place. Okay. A nurse case manager is coordinating care for a patient with hypertension and chronic kidney disease. What is the best intervention? And the one that you can't see is focus on monitoring blood pressure only. All right. Schedule regular multidisciplinary meetings And that's because they have the chronic kidney disease and the hypertension at the same time. So they'll probably have to see a specialist like a kidney doctor, nephrologist, and dietary, a few other people. A hypertensive patient presents with BP of 200/120, confusion, chest pain. What is the nurse's priority action? And that lower one is give patient fluids to lower blood pressure. The bottom one? Yeah, provide patient reassurance. This one might be a little bit tricky. Good. Notify the provider immediately. Yeah, Heather's in the lead. Okay. A patient with hypertension states, I take my meds only when my blood pressure feels high. What is the nurse's best response? And that lower one is you can adjust the dose based on how you feel. Yay, almost everybody got that one. It's important to take your medications or to keep your blood pressure controlled. And I think I've heard a patient actually say that before. All right. 4 correct answers for Mel. A nurse is teaching a patient with hypertension about lifestyle modifications. Which recommendation is appropriate? And that lower one is take antihypertensive only during symptoms. Good. Yeah, reduce sodium intake to less than 2,300 a day. Good. And we want them to be able to exercise more. In the long run, that could lower blood pressure. All right, so Heather's still in the lead. 18 players have reached answer streak of 3 so far. A nurse is assessing the patient's understanding of hypertension. Which statement indicates a need for further teaching? And that lower one is hypertension can cause damage to my kidneys. Good. I only need to take my medications when my blood pressure feels high. Heather's still in the lead by a couple 100 points. Okay. Which patient behavior suggests effective management of hypertension? And that lower one is states, I will only avoid salty foods on the weekends. All right, almost everybody got that right. Good. Reports reduced salt intake and exercise regularly. Okay. And what is the priority nursing goal for a patient with newly diagnosed hypertension? And the bottom one is avoid hypertensive medications until symptoms develop. Good, almost everybody got that one. And sometimes it takes longer than 24 hours to reduce blood pressure for stability. Ooh, Hannah's in the lead and Heather falls to level 4. Okay. True or false? A patient with blood pressure of 190 over 120 is diagnosed with hypertensive crisis. The nurse should lower blood pressure as quickly as possible. Close. False. If they're in a hypertensive crisis, we don't want to drop that blood pressure so low because of the brain function, because the high blood pressure is adding a lot of brain or blood and oxygen to the brain. So if you drop it too low, then that's going to go away pretty quickly. So we want to gradually decrease that blood pressure, increase cranial. Yeah, I think I lost my thought there. So, and I think that was in a section of the hypertensive crisis in the book. All right. Oh, Heather is off the board. A patient with hypertension is following the DASH diet. What foods should the nurse recommend? And that lower one is fresh fruits, vegetables, and low-fat dairy. All right, we got it. Good. Everybody got that one right. All right. Ashley is ahead now. A patient with chronic hypertension asks how to prevent complications. What is the best advice? And the lower one is stop taking medications after BP normalizes. All right, we all got it. Good job. Reduce salt intake, exercise regularly, and take medications as prescribed. Next. During follow-up, a hypertensive patient is 135 over 85. After starting the DASH diet, what should the nurse emphasize? And that lower one is discontinuing medications immediately. And almost everybody got that one right. Good. A nurse is planning care for a patient with newly diagnosed hypertension. What is the goal, or what goal is the most appropriate? And that lower one is the patient will stop antihypertensive medications within 3 months. Good. Patient will reduce blood pressure to below 140 over 90 within two months. All right, Jasmine's ahead. Okay. Come on, Heather, get back up. What is the primary pathophysiology or pathological cause of coronary artery disease? And that lower one is hyperactive immune response. Good. 17 got the correct answer. High HDL levels is a risk factor, but pathophysiological cause would be the atherosclerosis, if I can even say that, of the coronary arteries. And all right, Heather's on the board again. Okay. A patient reports chest pain during exercise that subsides with rest. What type of angina is this? And the lower one is silent ischemia. Good. 16 got it right. Stable angina. And let's see, variant or Prince metal angina. But the correct answer is stable angina. Which lifestyle change is most effective in reducing CAD risk? And that bottom one is smoking cessation. Right, almost everybody got that one. Good. Okay, let's see where we're at here. And Jasmine's still ahead. And Heather's number 3. Which findings suggest that the patient's CAD is worsening? And that bottom one is LDL cholesterol reduced to 100 milligrams per deciliter. All right, almost everybody got that one right. Chest pain at rest lasting longer than usual. And remember, chest pain that resolves with rest is stable angina. Okay. What is the priority intervention for a patient experiencing unstable angina? And that lower one is encouraging patient to rest. All right. Almost everybody got that one right. Administer nitroglycerin as prescribed. And the 2 that got encourage patient to rest. We could do that, but they have unstable angina. So that means that their pain doesn't go away with rest. Now, which medication is commonly prescribed to lower cholesterol in CAD patients? And the lower one is metformin. Oh, I guess it's on this side. All right, Vastatin, or Lipitor would be the easier name. Good. All right, Hannah's in the lead. Patient with CAD is prescribed nitro for chest pain. What is the essential teaching point? And this one is use nitroglycerin only for severe pain. Good. Sit down before taking nitro. Why do you think we want to do that? Yeah, could cause dizziness, headaches. Yeah, and it'll lower blood pressure to a certain extent as well. We don't want them falling over. All right, well, Heather's creeping up there. Okay. What is the primary goal of collaborative care and CAD management? And that one is eliminate all risk factors. Alrighty. Now reduce myocardial oxygen demand. So that's the biggest goal. We can't really cure atherosclerosis. We could stent it if we needed to. Can't really eliminate all risk factors, and we don't want to promote weight gain. Righty. A patient with CAD states they feel scared about their condition. What is the best nursing response? And this one is, you're lucky to have survived. I think I've heard somebody mention that before. Oh, good. Everybody got that one. And can you tell me more about what makes you feel scared? And that kind of goes on our last week's lecture on open questions. Good. Ready. So far, so good. Okay, which assessment finding is most concerning in a patient with CAD? And this one's decreased appetite. If I move my head, can you see that okay? Oh, BP of 130/80. Good. Almost everybody got that one. New chest pain occurring at rest. So if they have unstable or stable angina, which the pain goes away with rest, then they start to develop pain during rest. That's a really concerning assessment finding. Patient reports nausea and jaw pain. What should the nurse suspect? And the one over here is anxiety attack. Stable angina. All right, acute myocardial infarction. Good. Yeah, nausea and jaw pain. Oftentimes you'll see that as signs and symptoms. Breezy has a highest answer streak of 23. Not bad at all. Okay. What should the nurse emphasize to a CAD patient using nitroglycerin for angina? And then the green one is used daily to prevent angina episodes. Take up to 3 doses 5 minutes apart if pain persists. Good, we got that one. So, okay. Well, Heather's creeping up there again. Which nursing intervention helps reduce oxygen demand in CAD patients? And the green one is administering diuretics as prescribed. Then the yellow is promoting rest and limiting stress. Alrighty, good. Promoting rest and limiting stress. And if we start to run out of time before we get to heart failure, I'll probably skip a few of the CAD ones. A patient with CAD has persistent chest pain despite taking nitro. What is the priority action? And the green is reassure patient and monitor vital signs. And the yellow is encourage patient to drink water. All right, almost everybody got that one. Good. Yeah, we don't really want to administer more nitroglycerin. We don't want to drop their blood pressure too low. Let's see, about 10 minutes. And I think we're going to skip a few more of the CAD ones after this one. Chest pain that occurs unpredictably at rest and is not relieved by rest or nitro. What type of angina is this? And the green is silent ischemia. Yellow is variant angina. Unstable angina. Good. And I think we can skip it once we get on to the question. So I think we're going to go to heart failure here in a few seconds. And we're going to skip this one. And okay, Mr. Smith, diagnosed with heart failure, has a history of hypertension. What is the likely cause of his condition? And the green is valve disorder. The yellow, pulmonary embolism. Hypertension. That's the biggest cause of heart failure because you're stretching out those ventricles with that high blood pressure and it's losing some of its compliance to pump correctly. All right, Heather's in the lead. Okay. Miss Jones, with crackles in her lungs and dyspnea, is diagnosed with heart failure. What type does she have? So crackles in the lungs and dyspnea. The green is mixed heart failure, the yellow diastolic heart failure. All right, left side. A little bit of mixed there. So you would hear crackles on the left side because the left ventricle is not working as well. It's not pumping that oxygenated blood up through the system or the peripheral system, and it's backing up into the lungs. So you'll hear crackles on the for left-sided heart failure. All right. Mr. Lee reports weight gain, ascites, and swollen ankles. Which type of heart failure is suspected? The green is mixed, yellow, diastolic. Good. Right-sided. It's because all the unoxygenated blood is coming from the system, the peripheral, into the right atrium, the right ventricle. Right ventricle is not pumping as good. So some of that blood is backing up into the system, causing edema, could cause ascites. All right. Mrs. Green wakes at night gasping for air. What does this symptom indicate? And the green is pulmonary embolism. Yellow is dyspnea on exertion. And the answer was in our PowerPoint. Good. Almost everybody got that one. Paroxysmal nocturnal dyspnea. So it happens at night. All right, Heather's down second place. Mr. Johnson presents with pink, frothy sputum and severe dyspnea. What is a likely complication? The green is hypotension, and then the yellow is hypertension. Good, almost everybody got that. Acute pulmonary edema. Miss Taylor's jugular veins are distended, JVD. What does this suggest? The green is pulmonary embolism. The yellow is cardiogenic shock. All right, it's a mixed one. So right-sided heart failure, where everything's backing up into the system. And then you'll see the JVD. Hannah's in the lead. Mr. Harris has a ejection fraction of 35% after echocardiogram. What does this indicate? And the green is normal cardiac function, yellow heart failure with preserved ejection fraction. And almost everybody got that one. Good. Heart failure with reduced ejection fraction. And I don't recall what the book says, but the normal I've seen is usually 70 to 80%. Okay. We might be able to get through all this. The patient's BNP is elevated. What does this finding support? And the green is chronic kidney disease. Yellow is heart failure diagnosis. A little bit of mixed. So this one's heart failure diagnosis. BNP stands for brain natriuretic peptide. And when the heart gets stretched by hypertension or less compliance, it releases this BNP enzyme. And like if somebody has an elevated BNP, then we can diagnose them, well, the doctors can, with heart failure. So if you get a heart failure patient in clinicals, look up the BNP. 5 more minutes. Mrs. Walker has fluid retention due to heart failure. What medication should she expect? And the green is calcium channel blocker, yellow ACE inhibitor. Good. Loop diuretic. So Lasix is one of the most popular ones that we give for heart failure. And 10 more. Mr. Brown is prescribed a beta blocker. What is the purpose of this medication? The green is eliminate sodium retention. Yellow, increase oxygen demand. Good. Decreased heart rate and workload. So with a lot of heart failure patients, you'll see them with beta blocker and probably a diuretic. And I noticed it still has 20 seconds. I thought I changed it to 30, but maybe I didn't save it. Oh, do you? Oh, good to know. So probably did it for the first one then. All right, Heather's almost in the lead. A patient with heart failure asks about dietary changes. What is the best advice? And the green is eat high sodium snacks for energy. And the yellow is avoid all fluids entirely. All right, everybody got that one. Limit sodium to 2,000 milligrams per day. And that's because if they have a lot of sodium in their diet, all that sodium's floating around and the osmotic pressure is pulling the fluid into the system and then get overloaded. And it's worse when they have kidney disease. All right. Miss Carter, in acute pulmonary edema, struggles to breathe. What position is most appropriate? Semi-Fowler's with arms supported is green, and Trendelenburg position for yellow. The picture might give it away. Good. Let's see. Semi-Fowler's with arms supported. Yeah, we want them sitting up as straight as possible. A couple more minutes. Mr. Adams, a chronic heart failure asks about long-term goals. What should the nurse emphasize? Green is eliminate exercise completely. Yellow is increase sodium intake for energy. Good, almost everybody got that one. Prevent further damage and manage symptoms. That's our primary goal. I think we'll do one more, and these are based on the PowerPoint that is posted. So if we don't get through all of them, just look at that information. And we'll see if Heather can pull up to the lead after this one. A patient has clear lungs and no edema. What does this finding indicate in heart failure management? The green is pulmonary edema is present. Yellow is heart failure is cured. Right, almost everybody got that one. Treatment is effective. If there was fluid retention, we would hear crackles. Heart failure is cured. It's not curable. And pulmonary edema is present. Not true. So let's see who won this one. So Hannah is the new winner. And Heather is second. So your incentive is that you didn't get to hear me talk the whole 2 hours via PowerPoint. And I think we are out of time. All right, any questions before you go? Good. Well, thanks for coming. Let's do this again next week with a different topic. Let's exit that.
I'm trying to get it.
And,
But thank you very much for bringing them. It's delicious.
all right, Curry, have a good day.
You too, thank you.
And